Well, I think we're going to get started here. It's a little after 7 o'clock. I just want to welcome everybody to Grand Rounds again. It's hard to believe it's November in preparation for Thanksgiving and the holidays, but we're very happy for our speaker. Ann Susskind's going to do the introductions. Ann?
All right, thank you, Marshall. And I have the distinct honor and privilege of introducing our esteemed Grand Round speaker today, Jennifer Anger. Dr. Anger did a residency at NYU, followed by a fellowship in FPMRS at Duke. She then joined the faculty at UCLA and did an MPH under the direction of Mark Litwin, and really became the preeminent researcher in health services research in FPMRS. And a lot of the literature is really in her name, which is, she's just a giant in the field. And she's gone on to get many, many grants, too many to list, including funding agencies such as ARC, PCORI, NIH. She's had over 250 peer-reviewed publications. She went on from UCLA to go to Cedars for many years, and now is at UCSD, where she has reinvented herself once again as a gender-affirming surgeon. She's professor and vice chair of research at UCSD. She's, on top of all that, a wonderful human being. She's a supporter, a mentor, a sponsor of many, many urologists across the country, including myself. And she's also a beloved Zumba instructor. And so she's a true giant in the field. We're very, very pleased to have her today. And I will turn it over to her to share her some of her current work on her art grants. Dr. Anger, I give it over to you.
Thank you, Dr. Susskind, for that lovely introduction. And I'm honored to be here. And we have this nice UC collaborative that we're starting. And I was tasked to reach out to our different vice chairs to start a collaborative, which is early on, but really exciting. But so I was reaching out to the chairs of different departments, and I said, "Can you ask me who your vice chair is?" And Dr. Carroll's like, "Well, we really have about 5." And so I'm just I'm honored to be here to be able to talk to you at UCSF. The research that you do across urology is really so impressive, and I thank you for having me. I will start with sharing my slides. And does that look like that's working?
Yeah, it looks great.
Okay, great. So I always, I like to, when I make a talk, try to make it relevant. I feel like benign talks, if we do a good job, then they're relevant for oncology, and vice versa. When an oncologist speaks and it really speaks to me, I really think, wow, it's nice when we can talk about topics that really cover all of urology and not just benign, although the title of this slide is pretty specialized and focused on what I'm doing now. It really is a culmination of my career in health services research, which really started in 2004. So I trained with George Webster, and this is back in the day in 2003, 2004, where it was a combined male and female reconstructive fellowship, and later branched out into 2 fellowships where FPMRS became ACGME accredited, a 2-year program. So I'm really grateful for that kind of old school training, because it really led to what I'm doing now. And then I landed on Mark Litwin. I was about 7 months pregnant, had a research plan. I really wanted to stay in academics, had to move back to California for a man. And anyway, my kind of plans fell through. And luckily, Jean de Kernian just kind of, asked Mark Litwin for a favor. And I showed up at his door with no background in health services research, although I had done clinical research as a resident and really was kind of, passionate about academics. Mark Litwin said to me, "Well, maybe, even though you haven't really done anything in this field, maybe you're malleable." And that was true. And it actually, it shows when we make plans, God laughs. And so I landed on this amazing opportunity without really having any idea what health services research is. And what it is the study of access, cost, and quality of care. And it was largely termed outcomes research. And at the time, most of the work had been done. Mark Litwin really revolutionized the field, because we were no longer talking just about curing prostate cancer, but what are these outcomes? What's the quality of life for an incontinent man after prostatectomy, for a man who is impotent. And that really revolutionized our field, and we started looking at quality of life. So health services research is the study of the end results of health services, taking into account patient preferences, values, and experiences. And you can see how it's evolved a little bit from Campbell's 9th edition to the 11th edition here. So when we talk about access of care, a very popular model is the Anderson model, which is from UCLA, which talks about access as being like actual use of personal health services and everything that facilitates or impedes their use. And when we look at access to care, we're talking about predisposing factors, so health beliefs and attitudes. And when we look, for example, at gender affirming care, patients are often misgendered in the hospital. They get treated poorly, so they often avoid healthcare altogether. So avoidance of healthcare is actually an access problem. Enabling factors, so health insurance, how far does someone live for the hospital, as well as need factors, what is the disease that they're studying. So differences in access to care are a fundamental reason why we have disparities in health status among different populations. And when we looked at pelvic floor disorders, we find that and this was some focus group work that we did in English and Spanish in Los Angeles, as well as Albuquerque. And we found that Spanish-speaking women had different ideas about what prolapse might be. If they felt a bulge, they thought, oh, maybe this is cancer and surgery is dangerous. What am I going to do? So this kind of very scary feeling of having something falling vaginally and not knowing what it is. And then we look at enabling factors. So women who had to travel further to get to a clinic for surgical management of incontinence or prolapse were more likely to have surgery, largely because they couldn't go back and forth for, let's say, pessary treatment. So these are all what we call enabling factors that impact our access to care. Cost of care is very complex, as many of you know. It includes direct costs. So what are the costs for surgery, lab tests, medical therapy? But then especially with incontinence, we look at indirect costs. For example, insurance, wages, value of lost work. And this is actually across the board for many health conditions, what indirect costs are. One thing we don't think about is how much is a pad or a diaper or bedding. All these factors go into costs of care, but they're not really costs that we measure, but they're the direct costs that impact a patient. And we can measure care by utilization, length of stay. That's really, when we look at robotic surgery, length of stay is sort of a nice way for us as robotic surgeons to kind of justify a very, what would be an expensive procedure. Well, if it gets the patient home earlier because they have a lot less pain, then that's actually really a good value. And then we look at cost effectiveness analysis, which is a way that we compare costs and values of different healthcare interventions. And CEA helps to evaluate whether improvement in healthcare outcomes justify the cost. And this is complicated because we actually find a great deal of variation in care, and newer, better technology is not always associated with better outcomes. And so we don't really know, you can argue for different procedures that if it's more expensive, it's better, but that data is not very great. And we actually don't, there's a lot of controversy surrounding that. And then we look at life years. So when you're looking at cancer surgery, how many years of life do we save? And then a quality is a quality adjusted life year. So takes into account not only the life that you're, let's say, additional life you have by curing cancer, but are you incontinent or potent? And what is the value of those conditions? So analyses that rely on qualities are facilitated by estimation of patient utilities or preferences. So what does the patient want? What's important to the patient? Now I'd like to talk about quality, which the Institute of Medicine defines as the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So there's variation in care, a great deal of variation in care, and we're not, and this variation is not completely understood. But again, in a systematic review, there's inconclusive evidence that increased costs are actually associated with better care. And in urology, we love technology. And unfortunately, practice patterns are not always driven by data. And if you look at incontinence surgery, in which we rapidly shifted to the sling, we really didn't have great evidence that it was better than other technologies until many years later. Same with robotic technology. When we, in 2009, we miraculously got a challenge grant to study comparative efficacy of robotic versus open sacrocolpopexy for prolapse. And when we miraculously got this grant, my colleagues, my collaborators in Chicago, kind of sat me down and actually flew me out there. We were doing this great planning meeting, and they're like, we're not going to be able to recruit to the open arm. And I was like, but that's what our grant is. And they're like, we're not going to be able to do it. So they kind of twisted my arm, which was a good idea. And we entirely changed the grant to make it one of comparative efficacy of robotic versus pure lap sacrocolpopexy for prolapse, because we had already moved so fast that we couldn't even recruit for an open operation anymore. And so these kind of studies are like, if you look at open versus robotic, anything, it's really hard to recruit to the open arm. And this is just an example, and this was data from the Urologic Diseases in America project, which is amazing omnibus that Chris Seigel and Mark Litwin put together in the early 2000s, and really quantified burden of disease across the board for many benign conditions in urology. And it started careers for many of us. My first health services research projects were tables that they're like, oh, here, write this up as a paper. And because this really hadn't been done a lot in female urology, I kind of was able to present, and it started my career in this field, just really writing up a table that somebody else had done. And so I like to say, when you have if you're a new trainee interested in research, it's okay if you don't actually have ideas of your own. I think it's so important just to kind of learn from mentors, and then as you write up projects, you start becoming, later developing these ideas of your own. But anyway, this was showed rates of surgical procedures among Medicare beneficiaries. You can see the needle type suspension. So those were the RAWs, the STAMI suspensions were very popular in the early 1990s. And then collagen came out and rapidly took over. However, then we realized it didn't really work that well. And then the sling took over in 2001. What's important to know is that we didn't actually have data that showed the sling was better than other modalities until the sister trial, which was a stress incontinence surgical treatment efficacy trial. And Mike Alba published that with the UITN, which was the Urinary Incontinence Treatment Network. And this was in 2007. It showed that the sling is better than the Birch. But by then we had already moved on. We were done with that sling and had moved on to mesh slings. So you could just see how rapidly we shift procedures before we have data to support really what we're doing. For the most part, we're doing a good job, but we had problems with prolapse mesh kits, as many of you heard, and these were a high technology mesh kit that was placed vaginally and had a very high rate of mesh extrusion. And when performed by surgeons who didn't have the right surgical background, there were major complications, nerve injury, bladder injury, ureteral injuries, and these ultimately got taken off the market. And so for the most part, our rapid innovation as providers, we do a good job, but there's risk to that. And that's why it's so important to try to have our data supporting outcomes, fall in line, or be available more rapidly. So we found other examples of patterns of care when you have an ambulatory surgery center. There's increased use of discretionary surgery. When a physician owns the lithotripsy unit, they're more likely to choose that treatment for patients. And again, some advances have diffused more slowly despite evidence. For example, laparoscopic approaches to nephrectomy. And even now, if you look at myomectomy, there's still disparities in care where there's racial differences in who gets laparoscopic or robotic techniques, and underrepresented minorities are still more likely to get open surgery, which is a problem. And so when we have to try to diffuse our technology to all populations. And then the important thing is we must adjust for case mix and studying patterns of care, because high volume surgeons, who you would think would have better outcomes, may not have better outcomes because the cases that they do are complex. So again, the link between cost and quality is unclear, and just show that we need evidence on effectiveness, benefits, and harms of different treatment. And so I think what we want to do is do a little bit better job at identifying this link. So urology is at the forefront, and as we said, we love technology, and we always have exciting but expensive new drugs. And so we have to try to help people make rational healthcare choices. Unfortunately, when it comes to drugs, we often don't have that ability to give them to all our patients. And again, now we have a really good drug, and Ann Suskin is, as you all know, an expert in studying frailty in FPMRS, and anticholinergics are associated with dementia. We don't know if it's causal necessarily, but we have this great new class of drugs, which are beta agonists, and they're often not covered by insurance. And so what happens is, again, a disparity in care. So if you are underinsured, you're less likely to have access to these drugs, which are a lot safer than anticholinergics. So now I want to talk about the quality problem, and then sort of my really career trajectory. And again, for young investigators, I really copycatted Mark Litwin. He had done this great work on developing quality of care indicators for organ-confined prostate cancer. And after I sort of towards the end of my fellowship with him, I thought, well, why don't we do that for incontinence? And that was my very creative idea, which was a copycat of Mark Litwin, but that's okay. Often we take research that's done by somebody else and bring it into a new field. And so McGlynn did this very important paper where they use quality indicators, and I'll talk a little bit about what those are. But they found that patients only received about 55% of recommended care. And a project called the ACOVE project, which was assessing care of vulnerable elders, showed that there was a quality problem in the treatment of incontinence among older adults. And this is really bad. I mean, I think as patients get old, they, we think of incontinence as a normal part of aging. And although it's a highly prevalent condition, they can be treated. And so it's important, not only for older adults, but older and younger people, to try to maximize what we can do for them. So using the model by Donna Bedian, and this is from Michigan in 1966, medical quality comprises three components: structure, process, and outcome. So structure really is the setting of care, the resources of care, as well as provider experience. And this was my main fellowship project. Do high volume surgeons have better outcomes? And it's been shown in prostate cancer that yes, that is the case. What was interesting is we looked at claims-based data, which many of you are familiar with, but it has limitations. You can't look at pad weight or how severe your incontinence is, but you can always get good information when you're looking at patterns of surgery where there's a procedure code that's linked to the care that's given. And we found that high volume surgeons who did a lot of slings were more likely to address prolapse at the same time. and therefore their patient was less likely to have a reoperation for prolapse within a year of surgery. So this was totally unexpected. And it was actually interesting because it showed that, if you just do a sling here and there, you're probably not going to be addressing the cystocele. And so that was an important finding on the importance of volume in FPMRS. Physician specialty, when you look at melanoma, if you look at an oncologist, surgical oncology or derm, we're likely to have a better job than a general surgeon, to have a better margins and better care. Availability of urodynamics equipment. These are examples of structure. Process, or the interaction between patients and providers, informed consent, patient education, implementation of a treatment plan, surgical technique, which is very important, and also the elements of care that lead up to that surgery, history and physical, what elements of the workup are done. And then outcomes refer to the change in a patient's health status, which is likely due to these structural or process measures. The classic outcome is survival rate or disease-free survival, complications, reoperation, and then what's very important, in particular, often in our benign conditions and in all conditions, really, is health-related quality of life. So according to Donna Bedian, structural characteristics will influence process of care, so that which will influence quality, and then changes in the process of care, including variation in quality, will influence outcomes or effective care on healthcare status. And this model, therefore, provides a framework for quality of care research on incontinence. So again, talking about quality, the goal of my project, and this was for my K Award, which was a long time ago, 2007, was to develop indicators of care so that you can then measure care in the medical record. So a quality indicator is a little different than a guideline, although they're similar. A clinical guideline we talk about is the ceiling of care, the optimal care, sort of what should be done. And then a quality indicator is considered the floor. If you don't do X, it's considered bad care. So a quality indicator is a little bit more of like, what's the basic care you need to do? Whereas a clinical guideline is what's the optimal care you need to do. So in this, we first conducted a literature review to identify potential indicators of quality. And then we had structured interviews with providers and reviewed guidelines. And then from that, we conducted patient focus groups to try to find out what's important to patients. And these were focus groups for women with overactive bladder. And we addressed many topics, and we had very rich data finding out what they had to do, right? And how they were unable to get the help they needed. So they ended up taking care into their own hands. And if you can see at the bottom quote, first you go to the doctor for advice. And if that doesn't work, you start playing doctor yourself, doing what you think should be done. I mean, what can you do? And you would have a patient say, I know every bathroom in my neighborhood. Everywhere I go to the mall, where's the bathroom? I go to the store, where's the bathroom? And so you would see the experience of these women. And this definitely informed our development of quality indicators. And then we conducted what's called a Delphi method or RAND appropriateness panel, where we held a panel in person. And this was before the days of Zoom, which probably would have been what we would have done now. But we flew lots of experts out and had a 2-day panel. We reviewed candidate quality indicators. We actually had indicators for specialists and generalists. It really encompassed care at the primary care and specialty level. And one thing I always like to recommend, if you get funded to do one thing, you want to do 2 things. So I just threw prolapse in there too, even though that wasn't where my funding was. It allowed us to, if you have a whole panel, why don't you do one extra step? And then also, and so basically we were able to also develop indicators for prolapse. And we addressed many elements of care, but mostly process measures. It's hard to have a quality indicator Really, these are focused on process, but you can also assess outcomes, for example, which is a process measure as well. But that we put these indicators in an if, then, because format. If a woman undergoes surgery for stress incontinence, then she should have a cystoscopy intraoperatively because missed injuries result in delayed mesh-related complications. So then we held this panel. We had urology, urogyne, internal medicine, geriatrics, and health services researchers. And then this is just showing how we rank the indicators in a pre-ranking that was done electronically. We had panel discussion and re-rank the indicators, and then develop the final set of quality indicators. And the next step is a pilot test to see if they work. A quality indicator needs to be something that you can identify in a medical record. So this is just showing how we would rank. So the disagreement, and this is kind of funny because we actually disagreed that a woman should be screened for UI, although now it's a Medicare star measure to screen for UI. The reason we didn't have it in our panel is because you don't want to screen if the patient's not bothered. And that's important because some women will have a teeny bit of leakage here and there, but it doesn't bother them. So we don't necessarily want to evaluate and treat non-bothersome incontinence. And then an agreement was an obvious one. If a woman has a vaginal bulge, she should have a pelvic exam. So that was a quality indicator, for example, that passed. And then, so if a woman undergoes stress incontinence surgery, she should have a pre-op stress test, undergo a post-void residual, not undergo preoperative cystoscopy. That's really not indicated because it's going to be done at the time of surgery, unless, of course, there's a problem with her urinalysis or microhematuria. And she should also be counseled about risks of mesh, because these processes constitute good care and are supported by expert opinion and clinical guidelines. So that's an example of the quality indicators. And then we did a feasibility test with these ACOV charts and showed that there was a big deficit in care. We compared care in ACOV, which was, again, the vulnerable elder population, and they only received 38% of necessary care. Only 38% had a pelvic exam. Then we looked at a multi-specialty medical group, which was Cedars-Sinai and at the time, and we also looked at private offices at UCLA, and they had very good compliance with pelvic exam, but that's largely because of specialists seeing these patients, which is part of which can be a problem too, because a specialist ideally will see a patient after primary care management is done. And so anyway, but we did find there were deficits in care across the board. So like only 50% in both groups, 15% had documentation that pelvic floor exercises were offered. And we know that these are effective for patients. Very few had a documentation that they were counseled about weight loss when they were overweight. And documentation of risks and benefits that included mesh was lacking in the chart, and only 9% of cases had documentation of the risks of mesh. Now, I imagine risks of mesh were discussed much more often than that, but it wasn't documented. And that's actually a problem too, because if you have mesh litigation, which was very common in the years to follow, you need, if you don't have that you documented mesh, you can't prove as a provider that you documented, that you talked to the patient about mesh complications. So then I applied for an R01, which didn't get funded, that addressed quality across the board, primary and specialty care. And the grant was too complex. And so then we revised the grant to study quality in the primary sector. And that didn't get funded either. But I had a really great program officer, Tamara Bavendam, who was a urologist. She was actually at UW for a while, and then she's since retired, and we're very sad about that. But she funded me with what's called an R56 grant to get preliminary data. And so we then focused the intervention on primary care. And then that didn't get funded either. And my last review was, well, this is dumb because specialists, well, they didn't say dumb. They said something like that, but they said specialists do a better job. So why do you care about, why are you trying to improve primary care management of UI? And so at that point, I was ready to kind of give up on this project. Luckily, I had funding in some other areas, interstitial cystitis, robotic surgery. So I had some other areas of where I had taken my research, but this was kind of my baby, but I was really ready to give up until AHRQ had a special request for applications focused on primary care management of incontinence. So that ultimately ended up getting funded, which was really thrilling. And what it shows is that, and I've had pretty good luck with responses to these special emphasis RFAs, because they care, they're passionate about what you want to apply for. And then the funding lines are a little bit better. So anyway, it got a not great score. It was a 35. And so I was ready to give up on it. But by that time, with this project, I'd developed some thick skin, and I was like, oh, well, I'm going to move on. And anyway, but it got funded even with a score of 35, which was really exciting. So we developed, so these are the indicators for primary care, and that served as our basis for measuring care as part of this incontinence intervention. And it's history, physical exam, urinalysis, behavior modification, starting meds, fluid restriction, and then beginning pharmacotherapy, and then not offering OAB medication for women with stress incontinence, which fortunately doesn't happen very often. And so and then follow up just to see, did the patient do better? So these are the basics of these primary care indicators. And and as we know, what we found in our pilot was that many women don't talk about incontinence. Providers don't talk about it. Providers weren't all that comfortable with it. And we would see a very, very early referral to a specialist. And when I say early, I mean patient emailed the provider on Epic and I'm having some incontinence, and the provider would say, okay, I'll put in a referral. Like, that was the primary care management. And that happened about 10% of the time. So what we were seeing is, especially in places where you have specialists, that there's a very quick referral to the specialist, which is fine for the patient. I mean, because they get probably good incontinence care, but it's bad for specialists because then you're not practicing at the top of your license. You want to see tertiary level care, but it's also costly. Specialists are expensive. And a lot of patients don't need to go to a specialist. They can be managed in primary care. So what we did was, based on the work done in Michigan, the Urological Surgical Quality Collaborative, which was led largely by David Miller. And what they had was they influenced community urologists to give better prostate cancer care. For example, workup of organ confined disease, avoiding extra CT scans. And they were able to have a clinical champion that went to these providers and help kind of teach them better, more cost-effective management and avoiding unnecessary testing. So we based our work on that, using what's called academic detailing or education. And this was a lecture that we gave. We gave smart sets that could be used, so clinical decision support. We gave a little pocket guide, and then also we reviewed their care on a one-on-one basis. We pulled charts with patients with the diagnosis of incontinence for the last year before the visit with the provider. And we looked at their care with them and said, this would have been a good opportunity to try medication. Here you could have recommended fluid restriction. So this one-on-one feedback was done to be able to improve how they're managing incontinence. And then we had a control group, which we gave an incontinence lecture for UTIs, which was just so they the control group kind of got something. The goal would be later for the control group to then get the intervention. And then we used REDCap to recruit patients by email. And so this was a pilot before we got funded. And we found that patients indicated that a lot of them had bothersome UI, but only half finished the survey. And the problem was we didn't actually pay patients, and that was my fault. It didn't occur to me to pay patients. It's really kind of silly, but one of my mentors was like, well, how much are you paying the patients? And I was like, oh, right. So if you want participation in any kind of recruitment tool, paying the patients is a good idea. And so, but even in the patients that they had bothersome UI, they completed the survey, only 21%, and the provider was participating. We also reached out to the provider and said, your patient screened positive for incontinence. Only 21% actually discussed incontinence with their PCP. So even when they screen positive and have bothersome incontinence, they're not likely to talk to the provider about it. And this can be because some patients are not comfortable, right? They need it, the doctor needs to bring it up. But what was interesting is when we did this screening tool, we actually got, and we were, IRB approval, we got patient complaints, which I didn't write the word complaint in the paper that we're working on publishing, but some said, you violated HIPAA. Why are you looking in my record? And then, so we had to modify the recruitment letter. They're like, I don't have incontinence. They got mad about that. Like, why do you think, who said I had incontinence? So we had to modify the letter and then change it from an incontinence questionnaire to a screening questionnaire from Cedars-Sinai. The other problem was PCPs didn't really respond when we emailed them. And this is just an example. We had to change this. The red is what we changed. Your primary care provider is participating in a quality improvement project. This is to understand if we can improve care. We do not know anything about your health. We don't know if you have incontinence. Your name was retrieved because you have an upcoming appointment. And we had one patient who worked in patient safety and complained to patient safety. It was really kind of a problem, right? So we modified the letter, and then it really worked better after that. But this was like, you realize like these little details, which sound like such an easy piece of this like research puzzle, end up really being like something that we have to work through, taking an implementation science approach. And so this is ultimately what we got funded by ARC. And we had this, my pilot, we didn't actually have enough patients in the pilot to show if the intervention worked, but we were able to show that it was feasible. And the doctors liked it. Even doctors who were kind of naysayers were willing to meet with me, and we were able to improve care. And they actually were able, we did show a reduction in referrals to specialists. So this is a 4-site study, originally through Cedars, UCLA, and Harbor. And then I moved to UCSD right before the study started. And so it ended up becoming a 4-site study. The goal is then to improve care and then ideally disseminate it across these different venues, including PCORI and AHRQ. And so the aims of the study are, can we improve quality of care? And this is by measuring through chart review. Can we determine, can we decrease wasteful referrals to specialists? And can we delay those referrals? So a delay would also be considered a good measure, an indicator that the intervention's working. Can we impact patient outcomes? And that's the hard part. And so it involves surveys of patients at 0, 3, and 6 months. And then as a third aim, an aim 3B, and I don't, for you and for many of those who do research, I love aim 3B. That's like, we want to look at this, but we don't know if there's actually a problem. So we're just going to put it as my aim 3B, because are there disparities in care? And can we improve them? So if you don't know if there's a disparity in care, you can't really make it an aim 3A because it'll get killed in grant review, right? So, but we wanted to there's very little data. And if you look at the stress incontinence guidelines, all the data in the guidelines are based on Caucasian people. And there's not, and Latinas have a high prevalence of pelvic floor disorders, but they're not studied. And I think it's so important all you have to do to study health in Latinas is have Spanish questionnaires, right? And it's a little tricky. It's ideal to have a bilingual research assistant, but if you don't, there's ways to kind of be able to get Spanish speakers to participate. So that was a large focus of this grant. All our questionnaires, we made sure to use validated questionnaires in English and in Spanish. So again, what's this intervention? So it's academic detailing, but if you look at academic detailing across the board, it makes modest improvements in care. But if you look, but a modest improvement is actually, if it affects a lot of doctors, you're making a significant impact. But in other studies that have been done, like by Neil Wanger in these primary care interventions in ACO, for example, they recommend, well, if you give better clinical decision support for providers, maybe that has an impact. But what two things we found have a really significant impact on care are APP co-management. And this has been done in a study in Canada where the if a doctor, if you tell doctors, primary care doctors, here's one more thing for you to do, they often don't want to do it. Like, they don't have time to manage incontinence when they're dealing with hypertension, diabetes, for example. So what they can do, and what the study has as an option, is they can have they refer to the APP. Even though our APPs are actually funded by urology, the APP is co-managing with the primary care doc. So if the doctor has no interest in incontinence, they can just refer to the APP, and then they'll still get the credit. And then the next thing, which I think is really unique, is electronic e-consult. And that actually started in the county in Los Angeles. So Harbor, UCLA, all the county systems have an electronic referral system. And it works because patients can't really go elsewhere, unfortunately. If a PPO patient is told you can't go to urology, they'll be like, yeah, I can, and they'll go to urology somewhere else. But in a HMO type of setting, or in a setting like a county hospital, there's an electronic referral. It's a totally separate, it happened before Epic. So they have this whole separate platform where a provider cannot refer unless they've done A, B, C, D. And so it actually forces providers to do certain steps before they refer. And when you look in the literature, APP co-management and e-consult actually had pretty significant impacts on care. And when we looked at quality of care, the county did better than private sector when it came to primary care management of incontinence. So, and then just to show you some of the complexities. So ARC said, well, this is a nice study. We're interested in funding it, but it's not going to reach enough offices. We recommend a crossover. So we're like, okay, we'll do this crossover. But if you can see, we're already almost a year into the grant. We've got IRB approval. We're starting to start the study. And we have to have a control arm where we get enough patients. And this is like 900 patients across 4 sites. We have to intervene, screen patients, and then measure patient outcomes 0, 3, and 6 months. As soon as we measure the quality of life, the outcomes in that patient group, when we finish the 6-month mark, then the offices have to cross over, and then they become an intervention group. And so the control arm is on the top, and the intervention arm's on the bottom. And every time, like, if you just look at this timeline, it's actually really, this is really kind of tricky. And it's a very stressful intervention because of this timeline, when you haven't studied the timeline to even know how fast is recruitment going to occur, right? So this is one, kind of what I talk about, like a trial and tribulation, is just this alone was the crossover group that we were kind of instructed to add. The next is one site, Harbor UCLA, has a very low income population that doesn't usually use email. So we can't screen them by email, we're screening them by phone call. And then, so once the doctor gets this training and then we start to screen their patients. So it's prospective in that way. So then we have English and Spanish. We found variation in some IRB policies, although that we have what's called a smart IRB. So the other sites are kind of forced to use UCSD's IRB, which is nice because it's a little more lenient. It allows you to contact patients, for example. So that was another challenge. The other is this screening tool, and this is screening by REDCap. And this is how we're screening. So your primary care providers participating in a research project. Many women have incontinence, involuntary leakage, but for one reason or another, do not tell their doctor about it. The purpose is to understand if we can improve care. So this is sort of this, and then it's a yes, no. Do you have new or worsening bothersome incontinence? Because again, we don't want to treat non-bothersome incontinence. And then this is sort of what we do, which I talked a little bit about. We meet with providers, doctors consent for either control or intervention, and they're randomized at the office level. Again, another barrier, because you have pods which count as an office, and then but it's hard to give a lecture when 4 pods, which are 4 offices, but they're in one, let's say, floor. You can't give them all one lecture because each pod kind of counts as an office. So you have to try to avoid contamination. We actually, to screen, we screen patients. And then because we had so much trouble getting a conversation to occur, we now got permission to have a BPA, or best practice alert. And I'll show you this. So again, the clinical decision support, we try to limit to study providers, and we have a different BPA for providers that are in the control group versus those in the intervention group, because we want a useful BPA. Now, these are the note templates, and then these are sort of, so this helps the providers with diagnosis, with ordering, follow-up, Kegels, all these things are kind of directing their care. And this is the BPA, your patient screen positive, please address their incontinence, because we have to give screening for both in control and intervention. Then here, this is the BPA, an example of what we would do for the intervention arm. So your patient screen positive, please use the order set. And so, this is just an example of them going into the order set. Now we kind of change this because we don't want them to quickly refer. So we actually don't have that on there. We want them to do management, and then they have this option to refer to an APP if they want. And so where we are now, these are just some more examples. They can actually refer specifically to an APP. They have to know they're in the study, which seems like that would be obvious, but that's not always as obvious. And then, so where we are, next steps were, as I mentioned, before this got funded, it had a 35 score. So I submitted, PCORI had a similar RFA, and we miraculously got that funded. So after 9 years of not getting my R01 funded, I now have this problem of having 2 very similar funding mechanisms for these incontinence interventions. So next, what we have, PCORI is a grant that they all get clinical decision support. They all get teaching or academic detailing, but then we randomize to electronic consult versus APP referral. And a large part of this grant is reducing disparities in care. And that's really a priority for PCORI. So anyway, I'll stop there so we can have some conversation, but thank you so much. I'm really excited to be here, and thank you for the opportunity.
All right, wonderful. Well, thank you so much for your excellent talk. And anyone in the audience, if you'd like to put in some questions, please put them in the Q&A box. The first question here is from Alan Schindel. And he's referring to the beginning of your talk when you talked about how we tend to create things faster than we can study them and understand them in terms of repercussions and outcomes. So how can we, or how should we, put the brakes on innovation or urology?
That's a great point. And I don't know if the answer is putting brakes on innovation. I just knowing what we do in urology, we love innovation. And I noticed that in at the WCET meeting, how they're very focused on innovation. So I think the really what we want to do is studying the impact of these technologies as soon as we can. I think trying to get data earlier was what I would think we would want to do. Assuring that there's safety associated with the innovation, I think, is where we want to go. And I apologize. There's lots of acronyms for the non-professionals, so that's very point well taken. And then let's see, there's another, let's see, a good surgeon can save my nerves. Let's see.
Here, and I can ask a question as well.
Oh, sure.
Yeah, so I love the work that you're doing at the interface of, integrating PCPs and specialists and trying to make the flow more efficient and optimizing the care for these patients. And, it can be a big challenge, and there is a lot of great work to be done there. PCPs, are so busy, right, and underpaid and overworked, and oftentimes it's hard to engage them for things like urinary incontinence, which might be very down on their list of all the multitude of comorbidities and problems that they have to manage. What are your best strategies for engaging PCPs, maybe who aren't so interested in this work, both clinically and for research?
That's a great point. And I should have mentioned that. So the key is having primary care leadership on board. And
Yeah.
we had this one of my friends at Cedars-Sinai, he's Jonathan Weiner, he's an internist. He's like, they have way too much to do. This is like, we can't do this. And we were like, oh God, we're not going to be able to do it. Right. And I had actually approached one of the VAs in San Diego about this, and they respectfully wrote me back saying no, but primary care leadership was really critical. And the other thing is, so it's important because screening is now a Medicare 5-star measure, and it's not mandated, but I think that's in the pipeline. So if you have a screening kind of requirement, you need to know what to do with the screen, right? And so I think that is a good sell. And the other way we sell it is we're trying to take the burden off of primary care. And the other thing is, it doesn't have to be perfect. Even though pelvic exam is a quality measure for primary care, as long as they had someone do a pelvic exam in the last year, it doesn't have to be the primary care provider. Did the patient see a GYN? Then that would actually count, right? So some things are not that, some indicators are going to not be that feasible for them. If you say you have to do a pelvic exam, they're going to be like, no, there's no way I have time to do a pelvic exam, right? And they may not be that comfortable with it. So we try to say, can you, when you go start with care that's 50%, it's not that hard to improve care. But again, I think having the leadership, because we ended up having primary care leadership kind of telling the primary care docs, this is what we want to do. But we also got primary docs when we gave the introduction to the study for different practices. A few reached out to me and say, I'd love to help with this. So we got primary care champions. And that's, I think, really important to people, not me telling them, this is what we need to do, but actually a primary care doc. That made a big difference.
Great.
Jennifer, did you need to incentivize these primary care docs to participate in these studies?
We didn't initially, but then we did. So it's the primary care docs fill out a knowledge survey, which we developed and validated actually, because the knowledge surveys that were out in the literature, I couldn't really understand myself. I couldn't tell what was right or wrong. I'm like, okay, we need a better knowledge survey. So they do get a money, Starbucks card. And then the thought was to give them a lunch at some point as well. I don't know your thoughts on that, Marshall, if you think that's like, what do you do or what do you recommend for that?
I think it's a big challenge, just getting people engaged and keeping them engaged in any kind of study. And some kind of reward system is worthwhile, but then it becomes a very tricky route. Are you paying them to do the study and all that? So, one is getting them engaged, and number two is keeping them engaged in the study.
Right. No, that's a good point. And we also had some we don't need, the other thing that's important is, and we have to document it, which is the hard part. We only need 3 to 5 docs per office because we're randomizing at the office level. That was sort of how we designed the study. So as long as a few will participate, then we're good. But we don't, if we wanted all the docs to participate, it'd be a lot harder, I think.
And then on the other hand, that's for the physician. About the patients, once you have them enrolled, how do you keep them engaged in the study also? Is there an incentive for the patient to have that 1 year follow-up after the 3 and 6 month follow-up?
Exactly. We have at this, they get paid kind of at each questionnaire. It's like a $10 money card. And it's simple urinary incontinence, the UDI-6, the urogenital distress inventory. It's a 6-item questionnaire. We also gave another questionnaire, the IC, like a 4-item ICIQ, the International Continence questionnaire, and then this knowledge questionnaire. So it's not a lot of questionnaire burden, and then they get a little money card at each point. And then after that, I hope they would just follow up for routine care after the 6-month mark.
In the final 2 minutes here, there's one more question from Dr. Matt Cooperberg, who says, great talk, and asks, is there any progress or thoughts on how to capture quality indicator data from disparate practices and documentation styles?
So that's a great question. And right now we have electronic records. 3 of the sites are Epic, one is Cerner. And so, but when you're talking about like maybe outside practices, which I think one problem for us for the PCORI, because I had to avoid overlap, we added Colby Soders, who's at Kansas. We had to add a totally different site. And then we're going to have to use different sites, probably like we have our community care, our Connect clinics that are kind of UCSD affiliated, but they're very separate. But our goal is to ideally use electronic record practices that have the electronic records so that we can ideally capture that. But yeah, if you have poor documentation, it's gonna probably translate to poor quality, and that may not be accurate. Maybe they're giving good quality, but they don't document it well. And so that we're not going to be able to capture that.
Yeah, it's all in the documentation. I imagine your smart phrases might help some with that.
Exactly.
Okay, wonderful. Well, the hour is up, but thank you so much for spending this time with us and for talking to us about this great work that you're doing. We really appreciate it.
Oh, thanks so much for having me. Have a great day, everybody.